Welcome back to the First Aid Neurology Review brought to you by Falcon Physician Reviews. In this section, we'll be focusing on neuropathology. Dementia correlates with a decrease in cognitive ability, memory, or function with intact consciousness. There are multiple forms of dementia. This slide illustrates the major high-yield features that are relevant to these diseases. Alzheimer's disease is the most common form of dementia in the elderly. Down syndrome patients have an increased risk of developing Alzheimer's-like pathology. There is a familial form, which comprises less than 10% of the total, associated with the following genes. For early onset disease, the mutations are found in the APP allele, the presenilin 1 gene found on chromosome 14, and the presenilin 2 gene found on chromosome 1. There is also a more common late onset version which has an association with the ApoE4 allele found on chromosome 19. It appears that the ApoE2 allele on chromosome 19 may be protective. Pathologically, what is found is widespread cortical atrophy, a decrease in acetylcholine derived from the nucleus basalis structures, multiple senile plaques, which are comprised of extracellular beta-amyloid core, which may cause an amyloid angiopathy, which can predispose patients to intracranial hemorrhage. Amyloid beta is synthesized by cleaving the amyloid protein. In addition, you find neurofibrillary tangles. These are intracellular, abnormally phosphorylated tau proteins. They become insoluble. These normally are part of the cytoskeleton, and the tangles that are found correlate with the degree of the cognitive impairment in this dementia. Pick's disease, which is a form of frontotemporal dementia, presents with a dementing illness, often with aphasia, Parkinsonian aspects, and changes in personality. Patients have sparing of the parietal lobe and the posterior two-thirds of the superior temporal gyrus. Pathologically, what's found are Pick bodies. These are intracellular aggregated forms of tau. You also find frontotemporal atrophy. Lewy body dementia is associated with Parkinsonism and dementia, commonly with vivid visual hallucinations. What's found are Lewy bodies, and Lewy bodies contain aggregations of alpha-synuclein. Creutzfeldt-Jakob disease, or CJD, is a form of a rapidly progressive dementia, progressing over weeks to months. These patients often have other signs, such as myoclonus. Pathologically, what's found is a spongiform change to the cerebral cortex, and the etiologic factor here are prion proteins, which transform from an alpha helix to a beta sheet, and these proteins are resistant to most proteases. Other causes of dementia are things such as multi-infarct dementia, which is likely the second most common form of dementia in the elderly, syphilis, HIV, vitamin B12 deficiency, or Wilson's disease. Another major source of neurologic morbidity is multiple sclerosis. This disease is fundamentally a disease of autoimmune inflammation and demyelination of the central nervous system, brain and spinal cord. These patients can present with optic neuritis, presenting as a sudden loss of vision, a medial longitudinal fascicular syndrome causing an internuclear ophthalmoplegia, hemiparesis, hemisensory symptoms, bladder or bowel incontinence. Often these patients have a relapsing and remitting course. It most often affects women in their 20s and 30s and is more common in whites. Laboratory findings are an increase in protein, primarily IgG production, in the CSF. Oligoclonal bands are diagnostic. MRI is frequently used and is becoming the gold standard for diagnosis. Some of the hallmark imaging findings are periventricular plaques, which are areas of oligodendrocyte loss and reactive gliosis, with the preservation of axons. Charcot's classic triad of MS is a sin. Patients will have scanning speech, intention tremor, often with incontinence and internuclear ophthalmoplegia and nystagmus. The treatments for MS are beta interferon or other forms of immunosuppressant therapies, and symptomatic treatment for things like neurogenic bladder, spasticity, and pain. Guillain-Barré syndrome, which is acute inflammatory demyelinating polyradiculopathy. Unlike MS, which is fundamentally a disease of the central nervous system, Guillain-Barré involves inflammation and demyelination of the peripheral nerves, as well as the fibers of the ventral roots. The sensory effects are often less severe than the motor effects. Patients will often have symmetric ascending muscle weakness beginning in distal lower extremities. Facial paralysis is seen in approximately 50% of cases. Autonomic function may be severely affected, for example, cardiac irregularities, hypertension, and hypotension, and are a major cause of morbidity for these patients. Almost all patients do survive this illness. The majority recover completely after weeks to months. Laboratory findings that are common are an increase in CSF protein with a normal cell count. This is also known as the albuminocytologic dissociation. In addition, when protein levels become very high, this can lead to papilledema. The cause of Guillain-Barré is not known, but is often associated with infections and is thought to be an autoimmune attack initially caused by the infection via molecular mimicry. The immune system then targets peripheral myelin, and that's what causes the disease. The most common cause, infectious-wise, for this is a Campylobacter jejuni infection or herpes virus infection. In addition, inoculations and perhaps stress may be involved, but there have not been definitive links made to particular pathogens. Respiratory support may be needed, and if needed, becomes critical until the patient's recovery. Additional treatments are things like plasmapheresis and IV gamma globulin. There are other diseases of myelin as well. For example, progressive multifocal leukoencephalopathy, or PML, is demyelination of the CNS due to destruction of oligodendrocytes. This is associated with reactivation of the JC virus and is seen in about 2 to 4% of patients with AIDS. This is a latent viral infection that infects a large percentage of the population and becomes reactivated in the setting of immunosuppression. This disease is rapidly progressive and usually fatal. Acute disseminated post-infectious encephalomyelitis, often called ADEM, is a multifocal perivenular inflammatory process that involves demyelination and is typically seen after infection, for example, chickenpox or measles, or after certain vaccinations, rabies or smallpox. Metachromatic leukodystrophy is an autosomal recessive lysosomal storage disease, most commonly due to aerosulfatase A deficiency. Patients with this deficiency will build up sulfatides, and this will lead to impaired production of the myelin sheath. A relatively common disorder is Charcot-Marie-Tooth disease, also known as hereditary motor and sensory neuropathy. This is a group of progressive hereditary nerve disorders related to the defective production of proteins involved in the structure and function of peripheral nerves or the myelin sheath. Seizures. Seizures are characterized by synchronized, pathologic, high-frequency neuronal action potential firing, and there are a variety of forms. Broadly speaking, there are two classes, partial and generalized. They differ based on how much of the brain is involved. In partial seizures, only a single area of the brain is involved, and most commonly, this is in the mesial temporal lobe. Often, patients with a partial seizure will have an aura that precedes the seizure. An aura is an abnormal sensory sensation. Some patients have simple partial seizures, which means that consciousness remains intact, meaning the seizure itself is some sort of motor, sensory, autonomic or psychic event, or they may have complex partial seizures where there's some impairment in their consciousness. Generalized seizures at some point in their evolution involve the whole cortex, and there are multiple types. Absence or petit mal seizures have a characteristic 3 Hz spike and wave morphology of the EEG, and there is no postictal or even preictal state. During the seizure itself, most patients have a blank stare without loss of motor tone and are often blinking and unresponsive during that state. Myoclonic seizures are quick, repetitive jerks. Tonic-clonic or grand mal seizures are alternating stiffening, often clonic activities, with relaxation. Tonic seizures are simply a stiffening posturing of the body. Atonic seizures are often called drop attacks. The patient will lose muscle tone and fall to the floor, and this is often mistaken for fainting. The term epilepsy refers to a disorder of recurrent seizures, and the seizures should be unprovoked. So, for example, febrile seizures are not considered to be epilepsy. The causes of seizures vary by age. Children often have genetic reasons or infections causing fever, which may cause seizure, trauma, congenital malformations, or metabolic reasons to have a seizure. Adults who have new onset seizures may have a tumor, trauma, stroke, or infection, and elderly patients with new onset seizures may have stroke, tumor, trauma, metabolic causes, or infection. Headache. Headache is pain due to irritation of structures within the skull that are pain sensitive, such as the dura, the cranial nerves, or extracranial structures. Recall that the brain parenchyma itself does not have sensory pain endings, so the pain is not coming directly from the brain. Migraines are typically unilateral headaches that consist of 4 to 72 hours of pulsating pain associated with nausea, photophobia, or phonophobia, often with an aura of some sort of neurologic symptom before the headache, usually including a visual, sensory, or speech disturbance. The headache itself is due to irritation of cranial nerve 5 and the release of substances such as substance P, calcitonin gene-related peptide or CGRP, or other vasoactive peptides. The treatments involve things like propranolol to help prevent the migraines, NSAIDs or sumatriptan for acute migraines. Tension headaches are typically bilateral, often last for more than 30 minutes, and have a steady quality to them rather than being pulsating. And they tend to not be so aggravated by light or noise and don't involve a neurologic symptom such as an aura. Cluster headaches are classically unilateral. These are repetitive, brief headaches characterized by periorbital pain with substantial autonomic abnormalities such as ipsilateral lacrimation, rhinorrhea, or Horner syndrome. These are much more common in males. They tend to come in clusters, that's why they're given this name, and the treatment for these is sumatriptan or related drugs. Other causes of headache are things like subarachnoid hemorrhage, and you should know this phrase, worst headache of life. The number one item on your differential diagnosis would be a subarachnoid hemorrhage due to a ruptured aneurysm. You can also find a headache in the setting of other neurological diseases such as meningitis, hydrocephalus, neoplasm, or arteritis. Vertigo is defined as the illusion of movement when the patient is not moving, and we should not confuse vertigo with very common complaints of things like lightheadedness or dizziness. There are essentially two kinds of vertigo, peripheral vertigo and central vertigo. Peripheral vertigo is much more common. It is due to some sort of inner ear pathology, for example, debris in the semicircular canals, vestibular nerve infection or inflammation, or Meniere's disease. and one can make this diagnosis through positional testing, for example, the observation of delayed horizontal nystagmus with rapid movement of the head. Central vertigo is due to brainstem or cerebellar lesions, for example, a problem in the vestibular nuclei or a posterior fossa tumor. Positional testing will produce immediate nystagmus in any direction, and the directions may in fact change. There are a number neurocutaneous disorders that are worth knowing about as well. For example, Sturge-Weber syndrome. This is a congenital disorder, and patients often have a classic port wine stain, sometimes referred to as a nevus flammeus. The stain is in the V1 distribution, that is the ophthalmic nerve, and the patients often have ipsilateral leptomeningeal angiomas, pheochromocytomas, and this disease can cause glaucoma, seizures, hemiparesis, even hemiatrophy, as well as mental retardation. This disease occurs sporadically. Tuberous sclerosis involves multiple hamartomas in the CNS, skin, and multiple organs. These patients can have cardiac rhabdomyomas, renal angiomyolipomas, subependymal giant cell astrocytomas. They can also have mitral regurgitation, seizures, hypopigmented so-called ash leaf spots, sebaceous adenomas, and shagreen patches. The disease is autosomal dominant. Neurofibromatosis type 1 or von Recklinghausen's disease. These patients can be recognized by their multiple cafe au lait spots. One can observe Lisch nodules. These are pigmented iris hamartomas. Neurofibromas are also seen in the skin. Optic gliomas are quite common. These patients can also have pheochromocytomas. The disease is autosomal dominant and is caused by a mutated NF1 gene on chromosome 17. Von Hippel-Lindau disease is a disease that involves multiple cavernous hemangiomas found in the skin, mucosa, and multiple organs. These patients can have bilateral renal cell carcinoma, hemangioblastomas in the retina, brainstem, and cerebellum, pheochromocytomas. This disease is autosomal dominant. It is caused by a mutation in the tumor suppressor gene, the von Hippel-Lindau gene, found on chromosome 3. Primary tumors of brain are a major cause of neurologic morbidity and mortality. Their clinical presentation is often due to mass effects. They can cause seizures, they can cause cognitive problems mimicking dementia, and they can cause focal neurologic deficits. Primary brain tumors rarely undergo metastasis. The majority of adult primary brain tumors are supratentorial, while the majority of childhood primary brain tumors are infratentorial. Note, about half of adult brain tumors are metastases. These are well-circumscribed tumors, usually present at the gray-white junction. Of the primary brain tumors, there are several types. Glioblastoma multiforme, which is a grade 4 astrocytoma, is the most common primary brain tumor, and patients with this tumor type have a grave prognosis. Typically, the life expectancy is about 1 year or perhaps less. These tumors are often found in the cerebral hemispheres, and they can cross the corpus callosum, giving the classical butterfly glioma appearance. Because the primary tumor cell type is an astrocyte, these tumors will stain for GFAP. Pathologically, what's seen are pseudopalisading pleomorphic tumor cells that border central areas of necrosis and hemorrhage. Meningiomas are the second most common primary brain tumor. These often occur in the convexities of the hemispheres and the parasagittal regions. These arise from the arachnoid cells external to the brain, and therefore these are often resectable and have a much better prognosis than the glioblastoma multiforme. Pathologically, what's found are spindle cells concentrically arranged in a whorled pattern, and these are called psammoma bodies. That is, they have laminated calcifications. Schwannomas are the third most common primary brain tumor. These are Schwann cell derived, and the most common place where they're found is localized to cranial nerve 8. These are called acoustic schwannomas or acoustic neuromas. These are also resectable, and they're usually found at the cerebellopontine angle. Pathologically, these cells are S100 positive. And whenever you hear of bilateral schwannomas, you should always be thinking about neurofibromatosis type 2. Oligodendrogliomas are relatively rare. These are slow-growing tumors, often seen in the frontal lobes, and pathologically have a chicken wire capillary pattern. In addition, the oligodendrocytes have a fried egg appearance, that is, they have round nuclei with clear cytoplasm. These tumors are often calcified as well. Pituitary adenomas also come in multiple types, depending on the cell type of origin. The most common type is a prolactinoma. These patients will often present with bitemporal hemianopia due to pressure on the optic chiasm. In addition, these patients can have neuroendocrine effects, such as hyper or hypopituitarism. These tumors are derived typically from Rathke's pouch. This figure illustrates the common sites for the various kinds of tumors described in the previous slide. The tumor types found in childhood are very different than those found in adults. For example, pilocytic or low-grade astrocytomas are commonly seen in children. These are usually well-circumscribed tumors, often found in the posterior fossa, although they may be supratentorial. Because they are derived from glial cells, that is, astrocytes, they are GFAP positive, and generally speaking, these are benign tumors with a good prognosis. Pathologically, these tumors have Rosenthal fibers. These are eosinophilic corkscrew fibers, and on gross observation, these tumors have both cystic and solid components. Medulloblastoma. These are highly malignant cerebellar tumors. These are a form of a primitive neuroectodermal tumor, often called PNETs. These tumors can compress the fourth ventricle, causing hydrocephalus. Pathologically, what's seen are rosettes or perivascular pseudorosette patterns of cells. Grossly, these tumors are solid, and histologically, one sees small blue cells. Therapeutically, these cells are quite radiosensitive, and radiotherapy can be used to treat these patients. Ependymomas. These are ependymal cell tumors most commonly found in the fourth ventricle. They can also cause hydrocephalus, and when this happens, prognosis tends to be poor. Pathologically, characteristic perivascular pseudorosettes are seen, as well as rod-shaped blepharoplasts, which are basal ciliary bodies found near the nucleus. Hemangioblastomas are often found in the cerebellum, and as mentioned before, these are associated with von Hippel-Lindau syndrome, particularly when found with retinal angiomas. These tumors can produce erythropoietin, causing secondary polycythemia. Pathologically, what's seen are foamy cells with high vascularity. Craniopharyngiomas are benign childhood tumors, often confused with pituitary adenomas, because these are found in the same location, and can also cause bitemporal hemianopias. These are the most common childhood supratentorial tumor. These tumors are derived from remnants of Rathke's pouch, and calcification is common to the point of having tooth enamel-like structures. This figure illustrates the common sites for the various kinds of childhood tumors described in the previous page. Note how most of them are found in the infratentorial space. There are a number of different herniation syndromes. For example, cingulate or subfalcine herniation is when herniation of the cingulate cortex occurs beneath the falx cerebri. This situation can compress the anterior cerebral artery, and this can cause secondary infarction in the anterior cerebral artery distribution. Downward transtentorial or central herniation is an extremely dangerous process which can cause coma and death when the brainstem is compressed. Uncal herniation is when the uncus of the temporal lobe is pushed under the tentorium and then compresses the midbrain. Cerebellar tonsillar herniation is when the tonsils of the cerebellum pass through the foramen magnum. Uncal herniation. Uncal herniation is normally associated with the following signs: ipsilateral dilated pupil and ptosis. This is caused by stretching of the third cranial nerve, and recall that this cranial nerve innervates the levator palpebrae. There is also a contralateral homonymous hemianopia caused by compression of the ipsilateral posterior cerebral artery, causing an infarction in the occipital cortex. In addition, ipsilateral paresis is found. This is caused by compression of the contralateral crus cerebri. This is also known as Kernahan's notch, and this is also given the moniker of a false localizing sign. And most worrisomely are Duret hemorrhages. These are hemorrhages in the distribution of the paramedian arteries. It's caused by rupture of these arteries, and these hemorrhages are then found in the brainstem. This is usually one of the last signs seen prior to death. Another high-yield topic is the differential diagnosis of radiographically detected brain lesions. Often these lesions are ring-enhancing, and the differential diagnosis of a ring-enhancing lesion would be a metastasis, an abscess, a toxoplasmosis lesion, or AIDS lymphoma. In contrast, uniformly enhancing lesions could be a lymphoma, meningioma, and occasionally metastases can enhance uniformly. Classically, glioblastoma multiforme will cause enhancement, but the enhancement will be very heterogeneous in its appearance. That concludes the neuropathological section of First Aid Neurology Review, brought to you by Falcon Physician Reviews.